This is always the fun, awkward time when we're just waiting for the webinar to start. All right, we'll go ahead. So good evening, everyone. My name is Melissa Wilson. I am the host of From the Clinic to the Living Room. We have a very special webinar tonight where we're going to introduce our newest member of the AIM team. Her name is Krista Rubin. She is our new AIMIT skin cancer Ask a Nurse. We'll talk about that a little bit later, but I just wanted to take some time to kind of explain what my role is first, because some of you on this webinar actually look kind of new to me. I've been doing this since 2019. I work as AIMIT Melanoma's Ask an Expert. I am the host of From the Clinic to the Living Room, and I have a series called Melanoma 101, where we kind of break down the topics of melanoma into itty bitty pieces that are a little bit easier to understand than the big giant topics. I've been, as I said, doing this since 2019. And when I first started, I was fielding questions both for melanoma and non-melanoma skin cancers. And actually now, wonderfully, I have a counterpart who is going to do the same type of role, but for AIM at Skin Cancer's website and their and her name is Krista Rubin. She's a nurse practitioner at Mass General Cancer Center in Boston, Massachusetts. Krista, it's very nice to see your beautiful face, and thank you for joining me tonight.
I'm so thrilled to be here, and it's so great to chat with you, Melissa.
Awesome. So I was joking earlier that I think that you probably could do my job as well, since I know you or know of you from all of the work that you've done in melanoma. Why don't you tell me a little bit about how you started in melanoma back in the day?
I hate to say it was probably even before you were born.
I doubt it.
Yeah, so I've been in the arena, if you will, of melanoma skin cancers since the late 90s, like 96, 97, back in the day where we didn't have as exciting treatments as we do now. And then I became a nurse practitioner and moved to another institution, moved to Mass General, and essentially my whole career as a nurse practitioner, now over 22 years or so, has been essentially in cutaneous oncology or specializing in skin cancers, both melanoma and the non-melanoma group of skin cancers as well. So seen a lot of change over the decades.
Lots of change. Yeah.
Lots of good change.
Born before you started
in
melanoma.
Right.
But I think our careers kind of are very parallel in that,
Right.
I joined the melanoma group a little bit later than you in 2005. And, this has been my only thing. Like, we have just been kind of chugging along in melanoma and cutaneous malignancies this entire time.
Right.
You are my perfect counterpoint for the AIMIT.
We'll be a good team, Melissa.
Great. So why don't you tell me a little bit about, obviously so much has changed, when I first started, even now, up until a couple of years ago, we did see the non-melanoma skin cancers in our clinic, but really there was not a lot to do in terms of treatments and adjuvant therapy. So, why don't you share a little bit about how things have kind of changed in this space over when you started into now?
Well, probably similar to you, the majority of the patients that we would see in our oncology clinics were primarily patients that had melanoma, because patients that had other types of skin cancers like squamous cell or basal cell or Merkel cell, those are the non-melanoma, the most common non-melanoma skin cancers. Those folks were often seen in other areas, as you know, like they would maybe stay with the dermatology folks, or they may see a radiation doctor, or another provider that wasn't going to give them what we call systemic or whole body therapy. So we didn't really see a lot of the patients that had the non-melanoma skin cancers. Maybe a couple of dozen per year. And I'm sure your practice is similar to mine. But then in the last, say, 5 to 8 years, there's just been an explosion of treatments that have been that are now available for patients that have advanced non-melanoma skin cancers like the squamous and the basal. And so in the oncology team, we see patients more because we're giving some of the drugs that oncologists are more or better equipped to give than, say, a dermatologist, where their expertise is different. So these immunotherapies are what these patients are receiving, and dramatically changing their lives for the good. Not everybody, but for the most part. So there have been just tremendous amounts of patients that normally wouldn't have been seen in oncology that are now being seen in oncology. So our practice has become busier and busier with patients with non-melanoma skin cancers. And in fact, we have a couple of doctors that have joined the team that essentially focus just on patients that have skin cancers that are not melanomas, whereas some of our doctors focus just on melanomas, because there are now so many patients that not enough doctors to go around with just with a focus just on one disease or another. And I'm sure your practice is similar to that, and with the influx of patients with non-melanoma skin cancers.
So you touched a little bit about how, the treatment of basal cell and Merkel cell and squamous cell are now utilizing immunotherapies. Do you want to talk a little bit about what those types of immunotherapies are? They're
Sure.
very similar to our melanoma patients
And in fact, most of the data, or most of the interest in treating patients with immunotherapies, has really come from patients with melanoma, because really melanoma is the disease that immunotherapies essentially started from. Even before we had these current immunotherapies, we had other ones. So back in the 90s, when I was on the floors treating patients, we used medications like interleukin-2 or interferon, which are also forms of immunotherapies, but they work very differently than the ones that we have now. But because melanoma is a cancer that traditionally hasn't really, it doesn't really utilize chemotherapy, kind of in the sense of, true chemotherapy or radiation therapy, it's really been a cancer that has not fared well from those modalities. And instead, immune therapy is really what has advanced the field. And so from that, there's always been an interest in the laboratory of what is it about melanoma that makes immunotherapies work so well. And it's really because melanoma is what we call immunogenic, or it's really, the way I like to describe it to my patients is it's a type of cancer that is intimately involved with the immune system. In other words, if we can figure out how to manipulate the immune system, someone's own immune system can attack the cancer. And essentially, that is the nuts and bolts of immunotherapy. And from that, there's been an evolution of understanding how the immune system interplays with cancer. And if we can kind of manipulate some of the pathways within the immune system, then we can turn on and off the brakes of what our body does to react to cancer. And so these immunotherapies essentially started in the arena of melanoma, and that's why those of us that do take care of patients with melanoma have broad experience in managing these medications. So the natural kind of history has been they've been tested in other skin cancers and have shown success in advanced skin cancers, in other words, that have spread to different parts of the body. And then with time, we're actually using those in an earlier and earlier stage of a person's disease. And in fact, that's one of the most exciting things right now, is we're really using these sometimes even before people have surgery. So for example, squamous cell carcinoma is a type of skin cancer that will often spread to lymph nodes or to the local area. And it's common in the head and neck area because that's where their sun shines often, right? So skin cancer is primarily from UV exposure, UV damage. And so our head and neck areas are often the most exposed. So it's very common to have skin cancers in those areas. So for example, squamous cell cancer that I just mentioned often spreads to lymph nodes. And those lymph nodes are generally managed by removal, because surgery is one of the ways to ultimately remove the cancer, as long as it hasn't spread. Well, what's happening now, which has been really exciting, is we're giving this in what's called the neoadjuvant setting. So neoadjuvant being using it before surgery so that you can ideally shrink the size of the involved cancer, making surgery a heck of a lot easier for the surgeon, but also somebody's recovery from surgery is much easier. And the other thing that has been proven in clinical trials, and so we have supportive data showing that if you give somebody these immunotherapies, some of these immunotherapies, while the tumor is still in the body or the cancer is still in the body, the immune system is able to learn it better, and it knows how to utilize what to do it's trained on that particular cancer. The cancer is then removed. So if there are any rogue or residual cells anywhere, the immune system is more likely to be able to identify it and take care of it. So again, that term is called neoadjuvant, so before surgery. And that's really been an exciting area of advancement because patients are doing so much better with these less, what we call morbid, or less side effects, or taking less time to recover from surgery has really been quite dramatic. And I'm sure you see that too. That's also happening in the world of melanoma
Oh my
as
gosh,
well, which
yeah,
is
that was the big
exciting,
news
right?
last year in melanoma,
Right, right.
neoadjuvant therapy. So certainly it's interesting to see that in terms of both non-melanoma and melanoma skin cancers, the themes are very similar. We actually have a question on Facebook asking a little bit more about basal cell carcinoma. So
Mm.
um, Jennifer from Facebook is asking, I had a melanoma 3 times and basal cell cancer once. Just curious what the treatment options for basal cell are. Now, obviously, surgery, if it is a removal situation where it hasn't metastasized, do you want to speak a little bit more about options once it has metastasized, or?
Sure. Now, metastasized basal cell is extraordinarily rare. It is
Very.
something that, it happens only, to a very small number of people. So we don't have large data sets to study, but there are enough people that have had situations in which they've been able to enroll into a clinical trial so we can learn how to manage these. And for the most part, surgery or some type of destruction of the basal cell is how it's managed. And generally that happens in dermatology. But as you mentioned, for those folks that do have basal cell that have spread, there is actually another category of medications that have helped many of those patients. And the medications are known as hedgehog inhibitors. And it's a cute little hedgehog
We
is
used
how
them in
they
melanoma too a long time ago.
is how they show them. But the hedgehog, it's actually a pathway in which the outside of a basal cell communicates with the inside of a basal cell. And the communication happens with all cells. But in the basal cell cancer, there is a very particular abnormality or abnormal signaling. It's kind of like a switch stuck in the on position. And these medications essentially shut that switch off and then disrupt that normal or abnormal signaling. And again, those are hedgehog inhibitors. They're pills that people can take if it's appropriate. And certainly there are instances when it would be appropriate and when it wouldn't be appropriate. And the treatment team would make that recommendation. But these are medications that can certainly treat that disease if it's spread. And then in some cases, if that doesn't work, there are the second line would actually be to go for one of the immunotherapies that treats basal cell if it has not responded to a hedgehog inhibitor. So again, another cancer that is now being involved with the immunotherapies. But for the most part, and the majority of patients, basal cells are easily cured with the dermatology provider. And in the rare instance that they do require more than just a surgery, then potentially the hedgehog inhibitors, followed by an immunotherapy if necessary. So that's exciting.
It is very exciting. I mean, those days also didn't really exist when we first started practicing medicine in this cutaneous forum. Jim from Facebook also, had said that he has a basal cell that started on his ear and spread to his bones, and he's taking Libtayo, and he's been on Vismodegib before. I hate that word. I can never say it.
They're hard to
stumbling.
None of these drugs are easy to pronounce. Yeah, so that's an example of the Vismodegib is a hedgehog inhibitor, and then the other drug Libtayo is a immunotherapy that can be used if the hedgehog inhibitor is not as effective. So great example of what I just alluded to.
I
So
know. That's
hopefully
why I was like, it's like
it was very timely.
leading you in this journey. Do you guys see a lot of Merkel cell in your practice where you are?
Yeah,
Yeah.
so Merkel cell is another one of those relatively aggressive non-melanoma skin cancers. And I really actually hate the term non-melanoma skin cancer
Oh,
because it kind of implies that they're less important or less serious when in fact, I think every cancer deserves respect. But just because there was a kind of a broad category when these were early, very early in learning about them, it was melanoma and then this whole other category. And so the new term for cutaneous, the new term for basal cell and squamous cell together are keratinocyte carcinomas. And essentially what that means is that tells you where the skin cancer arises from, the keratinocytes, which is essentially the top layer of our skin. And so then in the bottom layer of the skin are these Merkel cells. And interestingly enough, we actually don't know where Merkel cell arises from, but it is one of those rare skin cancers that unfortunately we do see a fair amount of as a tertiary care center or referral center. We do see a lot of patients referred in for Merkel cell. Having said that, it's also another disease that historically didn't really respond to most therapies. And now in the setting, in the kind of era of immunotherapies, this is also another group of cancers that is doing fairly well with immunotherapies. There are two immunotherapies that we generally use for patients that have advanced Merkel cell that cannot be removed surgically, and patients are having really, not everybody, but a lot of patients are benefiting with lots of extra years of survival and quality survival. So Merkel cell is also another cancer that is benefiting from this era of immunotherapy.
that's so nice. So we have a couple questions. I'm going to wait
Okay.
until the end, but I want to segue now into talking a little bit about, I mean, you're so knowledgeable. You have so much experience to bring to aim at skin cancer. So I wanted to talk a little bit about, what your role or how you feel your role is going to grow in this new setting with aim at skin cancer.
Yeah, so I hope I can answer that because I'm so new in this role. It has been less than a week, but I've already had some great questions. I think probably that's going to be the primary role, is being a resource, or at least being able to answer questions to the best of my ability to patients and families when they may have just been newly diagnosed. So the Ask a Nurse role is probably the number one role in that. Again, I'll be available to answer questions just as you do for melanoma. Be able to answer family and patient questions about general. I won't be able to specifically comment on their exact diagnosis or prognosis, but certainly can help provide some background information, or can say, that's right on, or let me put that into a different way of describing what your team has told you. So I think that's something I'm looking forward to being able to
I
at
will
least.
I mean, I will tell you that is the most rewarding part of this
Yeah,
job, to be
yeah,
honest, because you get those questions on Friday night or over the weekend where a patient will just get diagnosed, is completely freaked out, has Googled all of the things, and
right,
is, spiraling out of control, or
right.
just progressed, or may have just found out they had metastatic disease. And so I know for me, just being able to provide answers to their questions, sometimes questions that they don't necessarily feel comfortable asking their provider in the moment, or think it's a stupid question, or don't understand something, but kind of just are there for the ride during their appointment. So I think, like, for me, and I know for you, like, that's going to be the most rewarding, the most beneficial part of your new role, I think.
I agree. I mean, I've already had a couple of questions that it was simply translation. I mean, I think a
Yeah.
lot of what I do actually as a nurse practitioner is I sometimes consider myself the sweep team. I kind of go in and sweep up the mess that a patient is kind of left facing, and not because, the physician has put them in a mess,
Right.
but just because they're there, like hearing words they've never heard and then just like trying to figure out what's next. And so sometimes after, like you alluded to, they've stepped away, they've had time to think, now they're saying, gosh, I wish I had asked that question. And it may not be a specific question about them, but just kind of in general. So if I can help to take the stress away from somebody or just give them enough information that it makes sense.
Yeah.
I mean, we ask patients to make informed consent, or give informed consent or make informed decisions, but it's really hard to be completely informed. And so I think a lot of what this role will be is helping to inform patients to make the decision that is right for them, but together with their team. And I'm a big advocate of partnering with your provider. I think that's incredibly important to partner with your provider. I always say to my patients, you're the expert on you, and your medical team is the expert on the disease. So like together form a partnership and make the, be as successful as you can. So I hope that I can carry that forward into this role. And then also we're hoping to somewhere, similar to what you've done, is break down those kind of bigger topics into smaller, more edible pieces, like what is squamous mean? Like, okay, if I have melanoma, can that turn into a basal cell? Can that turn into a squamous? Like, not everybody knows anatomy really well, right? Like you and I went to school for a long time to learn this stuff. And then in our, respective fields, we've been learning every day. Well, somebody who's just been diagnosed has been thrown into this arena with not a lot to help them. So if we can provide through AIM some of that important supportive piece, then I think that they'll be able to understand what they're dealing with. And then, perhaps give advice that may they not have heard of that really makes sense. Like, for example, I tell people, get yourself a spiral notebook or a 3-ring notebook, keep everything in one place, write all your questions down, have your phone numbers down, like just have everything in one place so you can grab it and go. Or if somebody, sorry about that, if somebody calls, to answer a question, then you have everything written down in one place. And then simply bringing somebody else with you to an appointment. 2 sets of ears are always better than one. What you may not have heard, that your partner that's with you may have heard that differently. And so just simple things like that, I hope to be able to provide to patients and families, caregivers.
I'm like strategizing with patients about what questions they should ask their provider, like, is it appropriate to ask this question? Well, sure. If you're asking me, then you should ask them.
Exactly.
Where, it's not even so much teaching and explaining that. Of course, that's always a vital part of what I do. But there's sometimes where I'm someone's cheerleader, and I was like, no, you're on the right track. You need to ask these questions. And, I think, finding that balance, and it is hard sometimes, to not want to give someone advice and personalize, the answer. But, I think you will find, and I've found over the last couple of years of doing this, that, patients really understand that. And it's something that they're just happy to have a set of ears to listen to them and help them kind of guide through this process. So I
love what you said though about being a cheerleader too, because I think sometimes people just need that, like, you are, and to give them confidence to be able to, sometimes talking to physicians can be intimidating, especially if it's a first or second meeting. So giving them the confidence and being their cheerleader and tell them that, you have a right to know this information and ask questions. I think that's really important.
It's so vital. And you'll find that this is very much an extension of what you do every single day. So very rewarding. I know that the AIM at Skin Cancer is also going to, set you up with your own webinar. I know that's in the works. So look forward to seeing, Krista with guests and sometimes by yourself, teaching. And, I think that there's going to be such a great service for patients that, do have skin cancers that are not melanoma related. I mean, I've been trying to hold my own for the last couple of years, but admittedly, all of my special education and experience is primarily melanoma. So I am thrilled to have you join our team for sure. Was there any other things that you wanted to kind of talk about your new role before I get into a couple of questions before we sign off?
No, I think that it would be helpful to, hear some of the questions because that
Yeah.
may, if we get themes, then maybe that's something that we can talk more about in the future.
Very, very helpful. I actually, a lot of my webinars were from these initial sort of questions
Yeah.
that came up.
Yeah.
So Rebecca wanted to know, are they studying individualized vaccines for metastatic squamous cell? And if so, are they in trials, and what phases are those trials in?
Yeah, that's a good question. To date, I'm not aware of any of vaccines. Maybe you're alluding to the mRNA vaccine
Right, for
that we has
melanoma, right?
recently been introduced in melanoma. But to my knowledge, there isn't anything that's kind of coming closer in like phase 2 or phase 3 trials. Melissa, have you heard of anything? I am
No,
unaware. It may be
that's
in
why I
phase
was like,
one.
I'm interested to hear
Yeah.
because I don't actually know of any. So you're
Right, sure.
teaching me
Throw it
right
to
now too.
Krista.
I was like, no, I don't know.
No, but
Um,
hopefully, I mean, hopefully so. And I think the field is just advancing, and the researchers have such better understanding and technology, things like ctDNA or being able to draw blood and looking for DNA of cancer cells in the bloodstream. That's something that's not quite ready for prime time, but certainly is being utilized in the academic medical centers. That's something that's very exciting. So because of just the explosion of understanding of that intersection of the immune system and cancer, things are happening on a regular basis. So maybe next year, my answer to that question will be yes. But for
that's
right
great.
now, I'm going to say no.
Stay tuned.
Right.
So the next question, Lisa, is asking, is there genetic testing for basal cell or other of the cutaneous malignancies that are not melanoma?
Yeah, so that's a great question. The answer is yes and no. So there is one form of basal cell that is extraordinarily rare. That is a genetic condition known as a basal cell Nevis syndrome, or Gorlin syndrome is the other name for it. But that is not somebody that has a spontaneous 1 or 2 or 3 basal cells. That is a syndrome where people have hundreds of basal cells and they're diagnosed at a young age, and they generally have other medical conditions that go along with it. So for that genetic, that's a rare variant of that. For squamous, not to my knowledge. We do know that there is a genetic form of melanoma that certainly Melissa can talk more about. That is also very rare. So there isn't a genetic, but I will say that there is a hereditary component to skin cancers, in the sense of if you have a first-degree family member, mother, father, brother, sister, or child that has had a skin cancer, then you yourself are at risk, because we do know that there is a greater risk for somebody to have a skin cancer if they have a first-degree relative with it or a personal history. So if you've had one type of skin cancer, you are at risk for having another type of skin cancer.
Sure. Let me see. So Robin says, skin cancers are also very common in solid organ transplant patients. That's very true, Robin. And due to immunosuppressive drugs. And in these instances, immunotherapy is not an option. Are there any therapies are that do not rely on the immune system to be able to function, I guess is what she's kind of asking. So in patients that have immunosuppression, what options are available for those patients?
So, Robin, that's a great question. And I'll say I disagree. We actually do use immunotherapies in
Same.
patients who've had a transplant. In fact, we do it regularly. I will say that we are a center that has a lot of experience with immunotherapies. We have multiple subspecialty providers that work collaboratively to manage folks that are receiving these therapies. So it's not for everybody, but at centers with experience, centers, academic centers, it is something that is done fairly regularly. Again, it's case by case, but there are clinical trials and there are data supporting the safety of doing so. For example, somebody with a kidney transplant, we regularly would use, I don't want to say regularly, maybe that's not fair to say, but we have a number of patients who've had kidney transplant or other solid organ transplants that are undergoing immunotherapy and actually doing quite well. And it's not just transplant too. Patients who have other underlying immune disorders, for example, rheumatoid arthritis or colitis, in certain situations, these medications are given safely and again with subspecialty providers and in an experienced center. So it's not an absolute contraindication.
And you touched on something that I think is a really important theme, and I think is really even more so important in cutaneous malignancies, is that multidisciplinary approach. So, we have surgeons and radiation oncologists, but we also have rheumatologists and nephrologists and endocrinologists that are all part of our, speed dial because of the immunotherapy aspect.
And Melissa, as that's like the perfect segue into that is going to actually be the topic of my first solo webinar. So I don't know if you did that on purpose or not, or strategically, introduce that, but that is going to be the topic, the importance of multidisciplinary care for patients receiving immunotherapies or patients with cutaneous malignancies receiving these. So I can't emphasize this enough and totally agree with you that collaboration is key to success.
Yay. So we've reached the 7:30 mark. I know we have a couple of more questions. It's up to you whether you want to stay on and answer. I might close the questions for now if you decide you want to answer a couple more. If not, I'll send you these questions and then, they can be good inspiration. I always, preface by saying like, we could stay on here probably until 10 o'clock at night answering questions. So, at some point we kind of, have to end this webinar, but
how about if I take one more question, because I want to respect everybody's time as well.
Exactly. So this one is actually like a good education question. So Mitchell asks, what about actinic keratoses? Are these a concern? What is the best treatment and daily care?
Yeah, that's a great question. So actinic keratoses are pre-squamous cells. So it's a pre-skin cancer. And what that means is that these may or may not develop into a cutaneous cancer, squamous cell. So actinic keratoses are kind of these crusty sometimes or hard spots that you can feel often more than you can see. And about 50% of them will spontaneously go away. The other 50% can or have the potential to evolve into a full-blown squamous cell carcinoma. So we do pay attention to those. And it can also be kind of a marker of the amount of sun damage somebody has. So if somebody has multiple actinic keratoses, it tells us that there's damage at the DNA level, and that person is at risk for developing a full-blown skin cancer. So these are often treated by spraying them with liquid nitrogen, or they can often, particularly if they're on the head and neck region or on the scalp, they'll do what's called field treatment with sometimes topical chemotherapies, such as 5-FU or something called imiquimod, and often blue light therapy, which is another treatment that can be given to kind of treat the cells that are damaged. The immune system basically is revved up in those areas, will hopefully destroy those, and then new like baby bottom soft skin grows back after, hopefully. They are it depends on where they're located, how many they are, what other somebody's medical problems are, whether or not they can tolerate some of these therapies. But we do pay attention to those actinics. And they should be treated, particularly if somebody is immune compromised or has some sort of underlying immune disorder, because they are more likely to convert into a squamous cell. So we do pay attention to those. And the management is local and generalized. And I'm a big advocate for seeing dermatology regularly for skin screenings.
For sure.
Yeah.
So that was a great explanation. And that's more of what you can expect from you in the future. So again, you're amazing. You have so much wealth of knowledge. I think you're going to be such a great point of contact and advocate for patients. Stay tuned for Krista's very first webinar coming up on multidisciplinary approach. But I think, this is a great way to kind of welcome you to the AIM family, introduce you. You're going to have a great time.
Thanks.
to
Really
meet
looking forward
really
to
awesome
it.
patients. Yeah, it's going to be great.
Looking forward to it. And thanks for having me tonight, Melissa.
Gosh, it's a pleasure. It was so nice to spend some time with you, and we'll talk to you very soon.
All right. Take care. Good night.
Thanks everyone for joining us. Have a good evening.